Yes.
A very good evening, a very warm welcome. Myself, Aishwarya Nair, welcome you all on behalf of the Pharm D Community for today's session on Overview of Management of Rheumatoid Arthritis by Dr. SUSHANT SHINDE. I'm thankful to all the participants from all over the country who have taken out their valuable time and are attending this evening talk. Pharm D Community has been created with the charter to provide free webinars by doctors and Pharm D doctors. We conduct these webinars solely for the purpose of pursuing interest, facilitate, and foster awareness and education in our chosen field of pharmacotherapeutics. Organizing this event wouldn't have been possible without the wholehearted support of my core committee members. Thanks to Kuldeep, Pooja, Vaishnavi, and Yami. It's my pleasure to release the flyer of our next webinar. The registration link will be posted in the chat box for both Zoom and YouTube. So this is the webinar which is upcoming on Wednesday. And our next webinar is, there's one more webinar which is coming up on Saturday. The links for both will be shared towards the end of the session. I'm thankful to our speaker for today, Dr. SUSHANT SHINDE, who is one of India's eminent rheumatologists. I'll hand over the session to my teammate Pooja to introduce our speaker for today evening. Over to you, Pooja.
Thank you, Aishwarya. Good evening, everyone. Our speaker for today is Dr. SUSHANT SHINDE. He has completed his MBBS from in the Institute of Medical Science, AIMS, New Delhi. He has also completed his research officership from the Rheumatology Unit, AIMS, New Delhi. He also has a certificate in European League against rheumatism. Professionally, he is currently practicing as a physician and rheumatologist at the Rheuma Clinic in Dadar and Quest Clinic in Goregaon. He is also the medical educator for Quest Medical Academy. He is also the founder and the trustee for Ram Vardayani Health Foundation. With this introduction, I now hand over the session to Dr. SUSHANT SHINDE. Over to you, sir.
Okay, so thank you so much for your kind introduction, and thank you, Aishwarya and your team, for inviting me for this talk. It's really a pleasure to be here. I can see you have a very strong community over here. There are a lot of students who have joined in, and I'm sure there are others who are watching this on YouTube Live and would be watching it later on as well. So again, thank you. And so the way this would go ahead is, quite honestly, I should put out some disclaimers before we start. The first disclaimer is I'm a practicing physician and my interest is in rheumatology. I will keep my talk limited to the clinical aspects as I understand them. This is while I'm going to speak, I would be mentioning drugs, but this is all going to be for the academic purposes only. Also, I would like this interaction to be, this session to be very as interactive as possible. As the organizers would permit, I would like to take questions as and when they arise. I would give you an overview of how things are in rheumatology in general, because this is not a field which many people are aware of. So I will take this opportunity to talk to you. Most of you are very young people and you are going to be in your experts in your field in times to come. But rheumatology is a field which is emerging. It is a field which has a lot of promise, and there is a lot of need and an unmet need in our country, where there are a lot of patients, but very few doctors, and even those few doctors are not known of. So you were very kind to describe me as an eminent rheumatologist. I should humbly say that is not what I am. I am at a very initial stage of my career as a physician, and I see a lot of patients in rheumatology. But there are a lot of brilliant rheumatologists in our country, and I'm sure you will meet them if you have not met them by now in your journey ahead. But unfortunately, our patients don't know about it. And I would want that by the time this seminar or webinar is done with, most of you carry some more information, so that tomorrow if you see a patient with rheumatic disease, you know whichever part of the country that you are in, where to guide them and how to kind of encourage them to be on the right track and not get dissuaded away from the right therapies. So with that in mind, let me first introduce. And so what I'm going to do is also I'm going to, I prefer talking in a, what you might say, very traditional model. I would like to write down what I'm talking so that if there are students, most of your students, so if there is anything of interest to you, you might want to write this down yourself. So I'm going to share my screen at this point. And I hope this is clearly visible to you. So this is on a writing pad. I'm just going to write down what I think should be known about rheumatoid arthritis. So first things first, when we talk about rheumatoid arthritis, there is a lot of things that go confusing about the name itself. Rheumatoid arthritis, when people start talking about it, there are a lot of misconceptions about what really are we talking about. So when we talk about rheumatoid arthritis, we have to remember that rheumatoid arthritis is the most common type of arthritis that we have, but it's the most common type of inflammatory arthritis. So rheumatoid arthritis is it's a member of a bigger family called inflammatory arthritis. And when we talk about inflammatory arthritis, the twin brother, or not the twin brother, but the bigger brother of inflammatory arthritis is osteoarthritis. So many terms, which in a matter of 2 minutes, I've just spoken about 3-4 new terms for a lot of us. I've said there is rheumatoid arthritis, there is inflammatory arthritis, and I've said there is osteoarthritis. Quickly, let me give you a brief of this. I know my topic is going to be about management, but I do not want anybody going back thinking that what I said is to be used somewhere else. It's a very specific management of rheumatoid. We need to know whom are we offering this therapy to. So a lot of us know patients who have arthritis. I can very clearly say, all of you, if you go back in your memory, you will know at least one person who has arthritis. And most of the people that you know who have arthritis are elderly. They are probably more than 50 years of age. They are probably having arthritis, that means joint disease of the knee joint, and problem only in the knee joint, nowhere else. Probably their knee joints pain when they start walking, and they are probably using a stick or something, or they're applying something for their knees. Those elderly patients who have no other problem most likely have the commonest form of arthritis, that is degenerative osteoarthritis. What does that mean? That means according to age, along with age, there has been a wear and tear of their joints, and that has led to degeneration of the joint, that is osteoarthritis. Osteoarthritis does have therapy, but that therapy is unfortunately not a lot of pharmacotherapy. It deals with a lot of physiotherapy. There can be pharmacotherapy in form of non-steroidal anti-inflammatory agents, which can be temporarily used. And sometimes you can use some other neuropathic pain-related drugs like duloxetine can be used nowadays. But all of that is temporary. Primary therapy there is physiotherapy and surgery. So the biggest chunk of arthritis that we see doesn't really have a lot of pharmacotherapy. That somehow brushes on to other arthritis, and many people start believing, in our country, a lot of people do believe, a lot of patients do believe that arthritis ko dawai nahi hoti. That's a misconception that we have borrowed from osteoarthritis. That is very common. Identifying osteoarthritis requires good history taking, requires x-rays, and it's very often an age-related disease. When I'm talking about rheumatoid or any other form of arthritis, as a rheumatologist, osteoarthritis is what an orthopedic surgeon is going to deal with. As a rheumatologist, as a physician, I would very often not deal with osteoarthritis. I would rather treat and deal with the other form. The other form was inflammatory arthritis. Now, what is inflammatory arthritis? How do we identify this particular entity called inflammatory arthritis? Inflammatory arthritis means that this can occur at any age. When I say young individuals, typically I would see someone between the age of 20 to 40 years who has started developing arthritis. Very often, now this can vary according to the disease. Inflammatory arthritis itself can have various types, of which again rheumatoid is the most common. But inflammatory arthritis is very often going to occur in women. So if I look at women and men, it is going to be more common in women than in men. And in women, again, it's going to be rheumatoid more common. So young women coming with arthritis, I should be thinking of inflammatory arthritis. But again, I told you that osteoarthritis is also going to occur in a lot of people. They could also be women. Just being a woman doesn't mean that that's going to be inflammatory arthritis. A young woman, along with that, coming to you with a very important symptom called morning stiffness. Now, this is something I very often am going to be looking out for. This is something I look out for to diagnose inflammatory arthritis. This is something I ask them when they come after I start therapy to see whether they're improving or not. What is this morning stiffness? They will tell you that the joints which are paining, They are the worst in the morning hours. When they wake up in the morning, all the joints have got stiff. It is rheumatoid, it could be in the hands. If it is spondyloarthropathy, it could be the back. But whichever joint is involved, they will tell you that the pain is the worst in the morning. That is very different from osteoarthritis. This osteoarthritis patient will tell you, when I start walking, it starts hurting. But this patient is going to tell you, when I wake up in the morning, when I have done nothing throughout the night, I just wake up and there is pain. And that pain actually improves as I start moving that particular joint. That is very classical of inflammatory arthritis. And the second thing, remember when I said osteoarthritis, I told you it's only the knee. Here, it is going to be very often, not always, but very often, it is going to be multiple joints which are going to be involved. So if you see someone coming with this complex of having morning stiffness and having multiple joints involved, I'm going to keep it very simple. That is when I start suspecting inflammatory arthritis. I'm not saying based on just this much I'll diagnose it, but I'm telling you, elderly person, not having morning stiffness, having only joint involvement, call it osteoarthritis. But a young person, in that female, having morning stiffness and multiple joint pains, think of inflammatory arthritis. That's how I start thinking. Now, within inflammatory arthritis, I also have inflammatory markers which help me to diagnose. So along with this, very often I use markers like erythrocyte sedimentation rate, ESR, or C-reactive protein. Either both or one of them is very often elevated at the time when I make the diagnosis of inflammatory arthritis. As I start my pharmacotherapy, I expect the patient to improve on this, I expect the patient to improve on this, and I expect the patient to improve on this over a period of time. So these are not only required for the diagnosis, they're also going to be required to be monitored as my pharmacotherapy starts. Now, the first thing that I wanted to highlight was this, that there is osteoarthritis, a big brother, and there is an inflammatory arthritis, an important small brother. Remember, inflammatory arthritis is occurring at a young age. So don't you think as these people are going to age, they will have components of osteoarthritis also? That does happen. So I do see a lot of patients who have inflammatory arthritis to begin with. 10 years down, they do develop osteoarthritis. But that's why it's so important for us to identify them early and treat them early and take care of this so that they don't develop a lot of osteoarthritis. This is the damage. This is the inflammation, right? Now, if that's clear, let me take one more baby step. If we have understood that there is a different entity called inflammatory arthritis, then we need to understand that within inflammatory arthritis, there can be variety of types. As I said, there are multiple types of inflammatory arthritis, but there are two types which are going to stand out prominent. Why do I need to know them? Because see, from outside, it might seem that all the drugs are the same. All the drugs are immunosuppressant. That's not completely true. When we use these drugs, we need to be sure that we have to tailor our therapy according to their underlying pathophysiologies or whatever we understand about their pathophysiologies. So there is enough evidence to say that these inflammatory arthritis do not behave exactly the same. They require different kinds of therapies. So let me dive into this second part detail that I want to know before I start my therapies, that within inflammatory arthritis, I can have two broad categories. The first category is rheumatoid arthritis. As I've already said by now, this is my third time to say this is the most common type of inflammatory arthritis. The second category is what is known as spondyloarthropathy. Spondyloarthritis or spondyloarthropathy, which some of you might have heard of as its more commoner or older name, ankylosing spondylitis. You might have heard this name, ankylosing spondylitis. Let me quickly, in the next 1 or 2 minutes, briefly run through what are the differences between these two so that we know that we are not mixing up the therapies. I shouldn't be telling a patient of rheumatoid that this will not work in you, something else will, whereas that was the treatment over here, right? So when I talk about rheumatoid arthritis, what do I know about it? What are the common pointers towards rheumatoid arthritis? Well, when I think of a patient of rheumatoid arthritis, it is very often going to be a female, she, not a he, right? Most of the times it's going to be a female. And this female patient is going to come to me saying, I have pain over here. So if you are able to see my video right now, you will be able to see what I'm doing. This is exactly what the patients say. They say that their patients come to me saying that the pain is in our hands. Right? Small joints of the hands, this is where the pain starts, and very often this is where most of the patients would have pain to begin with, swelling to begin with, and eventually, if you don't treat them well, I'm just going to share a slide with you over here. If you don't treat them well, eventually they are going to develop deformities. These deformities are something that my therapy should try and avoid. So if I get a lady who comes to me saying, I have morning stiffness, where? In my hands. I have joint pain, joint swelling, where? In my hands. Not in one joint, not just one finger. All the fingers, both the hands, I'm getting swelling and pain and stiffness. think of rheumatoid arthritis. This is what is going to be their classical symptoms. Does that mean they can't have knee pain? Of course they can. Does that mean they cannot have pain in the shoulder or ankle? Of course they can. But where is the most common site of pain? That is in my hands. So this kind of a history should alert you we are dealing more likely with rheumatoid arthritis. I'm not going to go into too many details of this description, so I'm just going to keep it superficial, but yet important salient points. A female coming with pain in the hands. Of course, ESR CRP is going to be high. Of course, she's going to have morning stiffness, but she can have plus minus one of these tests positive, either something known as rheumatoid factor, which is a blood parameter, or something known as anti-cyclic citrulinated peptide or anti-CCP. So one out of these markers is very often going to be positive. Again, it's not must that it should be positive, but most likely one of this is going to be positive. If I compare this on the other side I have spondyloarthropathy. This spondyloarthropathy is going to be a disease I'm going to see more likely in a male. It's going to be a young male, around 20-year-old, 15-year-old, 16-year-old, 25-year-old male. And this male is not going to come to me saying, "Mere haathon mein dard hota hai." No. This is a male who's going to come telling me, "I have backache. I have backache which is always there in the morning hours." Remember the features of inflammation that we have said. This is a patient who's going to come to you with morning stiffness. My back is stiff in the morning. Every time I wake up in the morning for 1 hour or so, I'm not able to move because my back is very stiff. Right? That is a patient of spondyloarthropathy. Typically, his lowermost joint, that is known as the sacroiliac joint, has inflammation, and that's why he has pain. Very often patients can complain of buttock pain. So today morning, the patient I was meeting was a 25-year-old person who at the age of 20 had started developing symptoms and typically had this feature that he had buttock pain. Of a few days it would pain on the right buttock, few days it would pain on the left buttock, right? So alternating buttock pain, that kind of a presentation is spondyloarthropathy. If you don't treat them well, this is going to start involving their upper spine and eventually you will find that their back gets stiff like a bamboo, known as the bamboo spine. So their primary features are not in the hands, their primary features are especially in the lower back, and in the lower back, their primary feature is pain on rest. Remember, most of you, if you are going to sit for this webinar for next 1 hour in one position, by the time you get up, you will start having some pain, right? But if you sit for very long times, that kind of a muscle pain is very common. But these patients will typically tell you when they're not doing anything abnormal, they're just sleeping, they got up and they had pain. Right? But when they started exercising, their pain went away. That kind of a pain, which comes on exercise, which comes on rest and goes away on exercise, is called inflammatory backache, and that's the characteristic of spondyloarthropathy. They would also have ESR and CRP high. They would also come to you with morning stiffness. They might have other joints getting involved, like the knee or the ankle. But like a parameter over here, they would have another parameter which is elevated or positive, a gene known as HLA-B27. So I repeat, I have introduced you to three new terminologies by now. I have introduced you to the idea that rheumatoid arthritis is an inflammatory arthritis, not an osteoarthritis. Within inflammatory arthritis, there are many types, of which one is rheumatoid. And rheumatoid arthritis is going to be predominantly a female coming with hand involvement. And there can be another type which we should not confuse with, known as spondyloarthropathy. The treatments are different. And these patients are usually men with lower backache. Now, my topic for today is management of this, not management of this. So tomorrow, if you see a patient and you find that the treatments are different from what I have said, be sure that you are asking the right questions. We should treat these patients well. Now, when we talk about management, what really are we going to be dealing with? So when I think of management, I would have to think of management not only in terms of pharmacotherapy, but in terms of investigations and pharmacotherapy and physiotherapy and other things, right? So what are the investigations I should be dealing with? These investigations are important because the drugs that we are going to use, they can have adverse effects. So what are the baseline investigations I need before I start therapy? What are the investigations I need as I start my therapy and I want to monitor the patient, right? So two categories of investigations that we need. One, before I start therapy. Second, after I start therapy, I need to monitor the patient every 3 weeks, 3 months, whatever, depending on what I have started, right? So let's go there. When I'm trying to diagnose rheumatoid arthritis and when I'm planning to start therapy, the investigations that I need are going to be complete blood count. I'm going to also highlight at this moment, what am I dealing with? What am I looking out for in this complete blood count? Important for us to know because, well, when we start drugs, that is also what is going to happen to these patients. I'm going to be watching out for the patient's hemoglobin. Very often the hemoglobin is going to be low, but the drug that I'm going to use, methotrexate, is sometimes possibly going to cause immunosuppression or deficiency of folic acid. So you need to watch out for hemoglobin before you start the therapy. Right? Hemoglobin very often is going to be low because of rheumatoid arthritis itself. Second thing I need to be watching out for is I need a normal WBC count. I need a normal platelet count before I start my drugs. These drugs are going to be sometimes going to suppress the bone marrow, so you need to have these parameters normal. Apart from complete blood count, I would need to look at the renal function. I don't need to do the entire renal function test, but I need to do a serum creatinine. I need the creatinine to be normal. I also need a liver function test, and for liver function test, SGOT and SGPT, or ALT and AST, SGPT. These are sufficient tests. I need them to be normal. Remember, your most important drug is methotrexate, and methotrexate can alter the renal liver functions. So be very careful when you're trying to start therapy in some patients with rheumatoid. We have to be very careful, and we have to look at these levels before we start them on therapy, right? Now, apart from this, do I need to do any tests? Well, India is a resource constrained setting. So a lot of things beyond this will depend on the resources that you have available. Where are you dealing with, which city, which town, which kind of setup are you in? If you are in a city like Bombay, where I am, where you are going to deal with patients who have the resources available, you have the labs available to do all the tests, well, you should investigate. But if I'm seeing a patient in maybe a primary healthcare center where getting even this much is going to be tough for me, I should have at least this much and start therapy and not withhold therapy. Right? So what are the other optional tests, if I might say, which I need? Because these are optional, not really because they're not required, but because you might not always have the resources to do them. So what are the other tests? I need viral markers. I should strive to look for hepatitis B virus and hepatitis C virus, HBsAg and anti-HCV. These are the tests I need. But why do I need them? Well, I need them. I'm sorry for that. So I need them. I'm sorry for that. So I should have plugged that off. So, okay. So I need these tests because I'm going to start some drugs which can have adverse effects on the liver. So I need to be looking at hepatitis B and hepatitis C if possible beforehand. If possible, I should also strive to get a chest X-ray. Now, again, this is optional. If possible, I should try to get this because I shouldn't be dealing with a patient who already has tuberculosis. What we do when I don't have the setting to do this is I ask the history of tuberculosis. Why so? Because I'm going to give drugs which are immunosuppressants. When I give an immunosuppressant drug, I don't want the patient to have an underlying tuberculosis which flared up, right? So I am going to look for the chest X-ray and rule out tuberculosis if there is a doubt. Now, other tests, I've already told you these two tests, they are required only once: rheumatoid factor and anti-CCP. These are the tests I would require to diagnose the patient. And of course, I would require to monitor this patient by looking at the patient's ESR, or remember, we are a resource constraint setting, so not both, or CRP. I need these tests at the beginning of my therapy. So before I start these patients of pharmacotherapy, some basic tests. I need complete blood count, renal function, liver function, optional tests like viral screening or chest X-rays, rheumatoid factor, anti-CCP only once to know what kind of disease I'm dealing with, ESR or CRP, one of them, to monitor the patient eventually. Once I start the patient on therapy, then what? Then I need these tests at least every 3 monthly. Not the other ones, but the first ones, I need them at least every 3 monthly. That means every 3 months, I should strive to get CBC done. I should strive to get the renal function tested. I should strive to get SGOT and HGPT tested. Very important, we need to ask the patient not to default on this, that if you're going to be on therapy, please get these tests done, right? What about rheumatoid factor? Do I need to keep on testing this again and again? Absolutely no. I've told you already that this is a one-time test, so this doesn't need to be repeated. What about ESR and CRP? Do I need to monitor them again and again? Preferably yes, because this will help me to tell if the inflammation has settled, the ESR will come down, CRP would come down. So preferably yes. Yes, I would prefer to do this every 3 months. But these are not optional. These I definitely need because I want to monitor adverse effects that might come out of my drugs, right? Okay, so now we are set to start the patient on treatment. We have done 3 things. We have tried to figure out whether this is rheumatoid or something else. Second, we have confirmed the diagnosis by doing some tests, running some tests like ESR-CRP, rheumatoid factor anti-CCP. And third, we know what to monitor when we start these patients on therapy. Now, when we start these patients on therapy, I would like to put out a question at this moment before I go further. Aishwarya ji, do I have your permission to do that? Can I put out a question at this point?
Yes, sir.
Yeah. So my question to you is, what is the drug of choice of rheumatoid arthritis? You could put it up in the chat box, I guess. What is the drug of choice for rheumatoid arthritis? What is the drug that you would want to give? If I give you a choice, give one drug. What is that drug which you'll give for rheumatoid arthritis?
So we have answers coming in the
Yes,
chat
I'm
box.
seeing the
Out
answers. No, I'm seeing the answers. Thank you. And I'm very glad that most of them are answering it correct. And I'm also glad that some of them are not answering it correct, so that gives me more room to know where our audience is coming from. Okay. So I would urge all of you to see into the chat box. You can see in the chat box so that you know what your colleagues are answering. Some of you are saying DMARDs. You're absolutely right if you say DMARDs, but which type of DMARD is the question? Okay, that's very interesting. That's very interesting. So thank you for your answers. I'm just going to start sharing my screen again, and I would quickly write down the options that I have got by now. Now, it's a good thing that none of you, maybe one odd answer has gone here or there, but most of you have at least enumerated the drugs which are used. The order might not be correct, but at least the drugs are right? So let's go there. What should I be thinking of when I'm treating a patient of rheumatoid arthritis? Without a doubt, the drug of choice is methotrexate, right? So if you're writing this, then you should know this without a doubt. If I'm talking about rheumatoid arthritis, remember I'm not talking about everything in rheumatology. I'm talking about rheumatoid arthritis. Without a doubt, your drug of choice is methotrexate. No doubt in that. There is perhaps nothing better than methotrexate that we have. As one of our senior rheumatologists, one of the very senior and respected person in rheumatology in India, as sir would very often say, make all the effort to see to it that your patient is on methotrexate and stays on methotrexate for as far as required and possible, right? So methotrexate is the sheet anchor drug. Now, when we talk about methotrexate, I would like to clear a few things that we need to know and few misconceptions that people have about methotrexate. First things first, whenever we think of methotrexate, we think of anti-cancer drugs. That's right, because it was introduced as an anti-cancer drug. But if you look at my oncology colleagues now, my oncologist colleagues now, those who are dealing with cancers today, they have such wonderful new drugs available today that they rarely are going to use methotrexate to control any form of cancer today. Right? It's almost outdated to use methotrexate in cancers now. Few odd conditions here and there maybe, but primarily it's not used there. When it was used there, it was used at a much higher dose. That was the high dose methotrexate. We guys have adopted that quite some time back, and what we use is a low dose methotrexate. So please remember, the methotrexate that is used in rheumatoid arthritis or in all rheumatic conditions is a low dose methotrexate. When we talk about low dose methotrexate, what dose are we talking about? The dose of methotrexate that we are talking about on an average would be somewhere between 10 milligram per week to 25 milligram per week, somewhere in between this. And the highlight point over here, it is per week. I'm not giving this as a daily therapy, right? Methotrexate has to be given in a low dose when we talk about rheumatoid arthritis, and that low dose is 10 to 25 milligram per week. Now, what are the rules? As a clinician, what do I follow? Well, the rules are I start with the lowest dose first. So when I start with methotrexate, typically I would start with something like 10 milligram per week. So let's say I start with 10 milligram per week. And I know it's going to be a slow drug. It's not going to be an overnight action. If I start methotrexate today, it's going to take few weeks, 6 weeks, 8 weeks, sometimes 12 weeks for my patient to start showing response. But I need to monitor because there can be hepatotoxicity. So when I ask the patient to come back, I would very often ask the patient to come back after 2 to 4 weeks with the liver function test, that is SGPT or SGOT. And I'm going to monitor first for toxicity. Remember, my rules are not that I'm going to see response first. I need to tell that to my patient that when I'm going to call you back the next time, it's unlikely that you have done well. it's most likely that you're doing the same or maybe slightly better than what it was last time. But I'm more interested first that I should do no harm. As a clinician, as people in the medical community, our first responsibility is do no harm. And in rheumatology, more than anywhere else, I have to tell my patient that my drugs can be potentially harmful. So I would first want to check whether you're tolerating. So I start with the lower dose, call the patient back after 2 to 4 weeks. If the patient has tolerated the dose, then I'm increasing the dose. Every time I'm going to increase the dose at the rate of 5 milligram per week, which means if I started with something like 10 milligram, after 2 to 4 weeks, I have reached a dose of something like 15 milligram to 20 milligram per week. Depending on how the patient has tolerated it, I might go to this dose. And then eventually I will increase the dose up to 25 milligram per week. So the first rule, don't give high dose, give a low dose, start with the lowest dose and escalate the dose every 2 to 4 weeks to see the maximum dose that you can reach. Maximum dose you should reach is 25. You don't need to reach there every time, but you need to watch out for the patient's toxicity. Now, the second obvious question is, if I'm going to start methotrexate, what am I really watching out for? How will I decide what dose to give? Now, here I would like to introduce you to the big brother that all of us are aware of, diabetes mellitus. Diabetes, high sugars, everybody knows about it. So I'm going to borrow that example for us today. When you start medicines in a patient of diabetes, is there a fixed dose of metformin? Is there a fixed dose of insulin? Is there a fixed dose of glimepiride? Answer is no. There are allowed doses, there are recommended doses, but the doses will vary from patient to patient depending on the patient's sugar. Similar principle in rheumatoid arthritis. Remember, I want to control inflammation. The inflammation that has happened in the patient has some clinical markers. Those clinical markers are swollen joints. Those clinical markers are tender joints, which means I press the joint and the patient will feel hurt. Those clinical markers are red joints. Those clinical markers are difficulty in moving the joint, restriction of movement. Those clinical markers, laboratory markers, are elevated ESR and CRP. So there are a variety of scoring scales that are available to us. As clinicians, we use them. And with time, of course, we use our clinical judgment of how the patient's inflammation is doing. Has the swollen count come down? Have the number of swollen joints settled down? Have the number of painful joints settled down? So maybe I started therapy, there were 10 joints which were painful when I pressed. Now there are just 5 joints, good improvement. But there were 10 joints to begin with, now there is just 9 joints still paining, not so good improvement. So I need to monitor the patient clinically, right? So what I'm looking for in every 2 to 4 weeks when I call back this patient initially is for a clinical response. Now, this is important for us to remember that I am not looking at only ESR and CRP. There is no one laboratory parameter that I'm trying to chase. I'm not trying to get my patient's lab reports fine. I'm trying to get my patient better. And there is enough evidence in science to say that if you can get the clinical response, that will prevent the damages from coming later on. Because this inflammation can later on cause erosions. It can actually cause permanent damages and deformities. So I need to get this inflammation corrected as early as possible. Now, typically, when I start with methotrexate, I'm going to look for this clinical response and I'm going to look for tender joint count. How many joints are painful when I press? I'm going to look for swollen joint count. I'm going to ask the patient, how much is your level of pain on a visual analog scale? On a visual analog scale, that means I'm going to ask the patient on a scale of 0 to 10 or 1 to 10, how much is your pain? You begin with, you told me the pain is 8 out of 10, excruciating pain. Now 2 weeks back, 2 weeks down, 4 weeks down, 2 months down, whenever I'm seeing you again, how much is the pain? Is it still 8 out of 10? No, doctor, it has come down to 4 out of 10. Good, there is improvement. And of course, I'm going to look for ESR. So I look for usually these 4 parameters: the tender joint count, the swollen joint count, the patient's pain on visual analog scale, and a blood marker ESR. Not just one thing. I'm not chasing one lab report. I'm looking at the patient's overall response. And based on that, I'm deciding whether or not I need to increase the doses. So if I start with 10, well, 10 is unlikely to control any patient at the beginning. So I start with 10, maybe I go to 15. I call back the patient. I see these reports again. I see the patient again. Maybe I go to 20. If the patient is not doing well, maybe I go to 25, right? Third rule. What is the form of therapy? Am I going to give oral therapy or am I going to give parenteral therapy? Well, to begin with, we would very often go with oral therapy. That's also because of the convenience. A lot of patients are not comfortable taking injectables. But as a thumb rule, remember, the moment you cross methotrexate of more than or equal to 15 milligram per week, patients start having some or the other GI adverse effect. They start feeling nausea especially, right? And this is a good time to consider switching over to subcutaneous therapy. Remember, it can be given subcutaneous, it can be given intramuscular, it can also be given intrathecal, in not used in RA, it is used more often in malignancies, was used in malignancies, but the preferred parenteral therapy is subcutaneous therapy. I like subcutaneous therapy because this is something which empowers our patients. Patients can take the subcutaneous doses like insulin doses on their own abdomen or thigh. So it really helps if you teach the patient this part. Some patients are not very comfortable, that's okay. But most patients, if they're taught well, if they're counseled well, they can take it themselves. It's very important. It's one thing to say, take a drug. It's another thing to ensure that they are able to take a drug. In the COVID era, it especially helped me if my patient was not able to take the drug himself or herself rather than going to a busy OPD somewhere else and getting exposed to COVID. So it makes sense that the patient tries to learn this. So below 15 milligram, oral therapy is okay. Above 15 milligram, subcutaneous is what I prefer. Unfortunately, there are going to be patients who are afraid of injections, and there I am okay if I give oral therapy, but this is my second choice. Preferred choice is subcutaneous therapy. Now, I've started the patient on therapy, I'm monitoring the patient, I'm giving this drug right. The next question is, if the patient responds, how long are you going to give this drug? So how long is this drug going to really go on? Well, this is going to be a clinical judgment. How long should the drug go on? This is a big question mark, but if you ask me, I'm going to tell my patient, don't consider, even if you respond absolutely well and you continue to do very well, there is no pain at all, nothing short than 3 to 5 years, am I even going to consider stopping the drug? That is not lifelong. Remember my big brother diabetes. There, if I start someone on insulin, that's going to be a lifelong affair. If I start someone on metformin and glimepiride, it's going to be a lifelong thing. Here, I'm going to tell my patient, if you are doing absolutely fine, 3 to 5 years is the minimum duration you are dealing with therapy. Again, most patients are not going to fall into this group. They are not going to do absolutely fine. They're going to do relatively better, much better in fact than what it was at the beginning, but it's unlikely that only methotrexate was able to control everything. Most of the patients are going to require something else. And when we think about something else, there comes in polytherapy. Now we need to consider more than methotrexate, right? So let me go to that second option now. If I have given methotrexate, and I have crossed the dose, which is 15 milligram, I have crossed, and I have given it for like a period of at least 2 to 3 months, and the patient still comes back having some tender joints, comes back having some swollen joints, comes back with ESR which is high, I would like to ask a question again to our audience over here. What would you like to do? Right? What would you like to do? So what other drug would you like to add? You have given methotrexate, that's a drug of choice. What next? Please put in your answers in the chat box. So I've given methotrexate. My question is, what next? What else would you do now? The patient has not responded to methotrexate alone. What next? What do you give now? And also, please, I'm sorry, but in your answer, do let me know what you do about methotrexate. Would you stop methotrexate and add something, or would you continue methotrexate and add whatever you're doing? So please refine your answers. I'm sorry, I should have highlighted that. So are you going to give methotrexate plus whatever you say, or are you going to stop methotrexate and add whatever you say? So stop methotrexate and your drug, or continue methotrexate and the drug that you're seeing. I'll also take a question which came in between. Should methotrexate be given in mild cases? The answer is it's a drug of choice for rheumatoid arthritis. If your diagnosis is rheumatoid arthritis, the answer is yes. In the earlier times, we used to prefer giving hydroxyquine in milder cases, but all we find is eventually these patients will require methotrexate later on. So yes, the answer today is if your diagnosis is rheumatoid, start with methotrexate. There can be variations in this answer. There are of course going to be some cases where I will go with hydroxyquine, but a general answer is methotrexate is the drug of choice, the first drug. So we have got a lot of options over here. What all to give? A lot of you have gone in favor of hydroxyquine, right? So hydroxyquine is also a very popular drug right now in the COVID era for many reasons, good or bad. It's right now in a lot of discussion. Now, if a patient does not respond to methotrexate, there is enough evidence to say that response to methotrexate is also a prognostic marker. If someone responds to methotrexate, that person is going to do much better than someone who does not primarily respond to methotrexate. Always, as a clinician, it is my job to make sure that before I label someone as not responding to methotrexate, I have taken enough care to take good history, ensure that the patient was actually taking the drug, taking it in the prescribed doses. For example, I might have told him take 7.5 milligram ke 2 tablet, that makes it 15. The patient forgot was taking only 1 tablet. It should not be like that. So if I've ensured that the patient has taken methotrexate and the patient has not responded up to 15 milligram, we do not stop methotrexate. We add to methotrexate. Remember, I told you right in the beginning, it's a drug of choice. It's the most important drug because it continues to work. Some patients might respond later on. So we don't stop methotrexate. We add to methotrexate. And what do we add to methotrexate? Now I'm going to talk about something which is very simplified version of what we do in reality, but it's something that as students, you'll find very helpful. So let us say I have given a patient methotrexate. Let us also say that I have given a dose of more than or equal to 15 milligram per week. And I have given it for a period of at least 8 to 12 weeks. So I've given it for ample time and I have found that the patient still continues to have the disease active. Now I have two options. The first option is I keep on adding drugs to methotrexate, which are oral therapy. And those oral therapy are also what are known as conventional DMARDs. Conventional disease modifying anti-rheumatic drugs. Conventional DMARDs. By the way, I should have highlighted over here, methotrexate itself is a conventional DMARD. And to that, I can add other conventional DMARDs. Conventional DMARDs, as the name suggests, are they have been there for a long time, 25, 30 years. We have been seeing these drugs. They are drugs which we are very well used to. They are quite easily available in India. They are cheap drugs. They're all oral therapies. I can keep on adding to methotrexate one out of these. Most of us would end up adding to methotrexate sulfasalazine in a dose of 1 to 2 gram per day. Again, not to begin with, I don't start directly with 2 gram. I start with something like 500 milligram, then 1 gram per day, then 1.5 milligram per day, then 2 gram per day. Eventually, I build it up over a few weeks. Very often to this, I would end up adding hydroxychloroquine in a dose of 200 to 400 milligram per day. Now, remember the doses that you might have heard of in COVID are very mild compared to these doses. And for some reason, hydroxychloroquine got a lot of bad publicity saying that it causes cardiac toxicity and all of that. Quite honestly, in my opinion, and also in opinion of a lot of other people who have been practicing rheumatology, we have not seen such cardiac effects with hydroxychloroquine. So it's not really right to say it causes a lot of cardiac effects. It does not. It does require monitoring for retinal toxicity, but cardiac effects are not really common. Of course, you need to do the due diligence, see that the patient does not have a renal dysfunction, something like that before you start the drug. But otherwise, you can give methotrexate plus sulfasalazine plus hydroxychloroquine. In the older times, these three together, which are still used, by the way, they were known as the triple therapy. We don't use that name nowadays a lot, but it will help you as students to remember this therapy, that a lot of patients in India will go home with methotrexate more than 15 milligram per week, with sulfasalazine between 1 to 2 gram per day, and hydroxychloroquine between 200 to 400 milligram per day. Right? This kind of a therapy very often will get those patients under control who were not being controlled only on methotrexate. What about leflunomide? Can we add that drug? Well, the answer is yes, you can add leflunomide as well. Now with leflunomide, the problem is the collective toxicity. You have an option to add a drug called leflunomide. The problem with leflunomide is it also causes liver toxicity the same way as methotrexate. So a lot of us avoid giving leflunomide and methotrexate together. Again, when I say avoid, I like to say this in medicine, there is never a never and there is never an always. Everything is relative. So very often, if possible, I will avoid giving methotrexate and leflunomide together. But there are going to be some patients who have really severe disease activity. In them, I might have to give it together. But in most cases, if I'm going to use leflunomide, I will substitute it in place of methotrexate. So you might get some patients who are on leflunomide, sulfasalazine, and hydroxyquine as a combination. So methotrexate and leflunomide can be used almost like substitutes to each other, right? Now, before I leave this arm, I would want to highlight something very important about leflunomide. Leflunomide overall is a good drug. Overall, it doesn't cause a lot of side effects. It's overall a reasonably good drug. I need to monitor some things when I give leflunomide, like I need to monitor the blood pressure. I need to monitor the patient for having peripheral neuropathy. That means some patients come with tingling sensation in hands and feet. But the most important precaution that I take when I give leflunomide is it has a risk of teratogenicity. And this risk of teratogenicity, well, that's with methotrexate as well. Remember, these are young women very often, between the 20 to 40. They might want to conceive. They might want to get pregnant and have a family. Now, leflunomide, if I stop the drug, let's say I have a patient who says that I need to start a drug. I need to start my family. I'm on a drug. Can I plan my family? With methotrexate, I need to stop the drug 3 months before the lady plans her pregnancy. I repeat, with methotrexate, if a lady wants to conceive while she's on methotrexate, I would ask her that I need to stop your drug now, and the conception can be, family planning can be after 3 months, right? There has to be a 3-month gap between stopping methotrexate and starting or planning for pregnancy. That's required because methotrexate's effect will go away by that much time, and the teratogenic effect of methotrexate will go away. We do not allow pregnancy while the lady is on methotrexate. But with leflunomide, there is a big problem. If the lady was taking leflunomide, it can, not always, but it can stay in circulation for up to 2 years. Now you can imagine this. If I tell a lady that stop the drug today and plan pregnancy after 2 years, that's going to be really difficult socially. And actually it's going to be a very difficult thing to promise and do, right? And what about those 2 years? What am I going to give? So the best thing you can do about leflunomide is start after the family is complete. Right? So if you're writing about leflunomide, this is one thing I would want you to remember. Don't give it to young kids. Don't give it to, young women. Give it to patients who are typically completed their family. And in practice, I would usually give it to women who are more than 40. Or I discuss with them that, are you going to plan pregnancy in future? If you are, I'm not going to give you leflunomide. I would rather give it to you later. Right? There are, of course, chelating agents available. If still the patient wants to go ahead with pregnancy after being on leflunomide, you'll have to give a chelating agent and remove the leflunomide from circulation, and only then give an okay for pregnancy. So my first arm of therapy is methotrexate plus the conventional DMARDs. But now, what has made this field really interesting is that we have other options. And some of you have written those other options in the chat box. I'm really glad that you're aware of these drugs. And those drugs are what are known as biologic DMARDs, right? Again, within them, there are categories. I'll not go there. But broadly speaking, the other option is, if a patient has not responded to methotrexate alone, I might give methotrexate plus, again, remember, methotrexate does not go away, plus what are known as biologic disease-modifying anti-rheumatic drugs. I can give biologic DMARDs in addition to methotrexate. Now, what are these biologic DMARDs? Now, these biologic DMARDs are very selective molecules. They selectively target certain types of molecules which are responsible for inflammation. Now, we do understand this. Now, in a very simple way, if I try to explain what these drugs are doing, think of it this way, that the body is having inflammation. Inflammation in the joints, that is inflammatory arthritis, that is rheumatoid arthritis. This inflammation requires us to have a coordinated attack by different cells on the organs, on the tissue over there. For coordinated attack by different cells like lymphocytes, monocytes, neutrophils, eosinophils, mast cells, whatever is going to do that attack. For that coordinated attack, there has to be a crosstalk between these cells. Think of it that way. And for a crosstalk between the cells, so that they all coordinate and attack together, they communicate with each other through certain molecules. If I can block selectively these molecules, the whole inflammation network cascade falls down and the inflammation comes to a halt. If I'm able to target such molecules which are responsible for the crosstalk, which are talking to each other and kind of increasing the inflammation that is happening, or sometimes I might target those molecules which are responsible for the cell proliferation itself, I can stop the inflammation. Those kind of molecules are what are called the biologic drugs, I'm going to share with you some of the biologics which are available in India. I'll come back to this slide, just remind me at the end of it. These are the biologics which are available in India, right? Not all of them. I should say that this second one is not available. So most of these biologics, I would rather say, are available in India. Just give me a second. I'm trying to see if I have the... Okay, I'm not able to write on this. Sorry, I thought I have the ability to write. So anyways, so there are different class of biologics which are overall available. You have the anti-tumor necrosis factor, of which infliximab, adalimumab, golimumab, and etanercept. These are available in India. Certolizumab is not yet available in India. Interleukin-1 receptor antagonist anakinra, not available in India, not even a popular drug nowadays. It's one of the earliest drugs that came in, but not very commonly used now. It's not even available in India. CTLA4 inhibitors or antibody against CTLA4, again abatacept, available in India, but the use is very less. Anti-TNF are used very frequently. Anti-CD20 rituximab, very important drug because it's available and used in rheumatoid. It's also used in many other conditions like SLE or some vasculitis. You will see this being used elsewhere. It's also a drug that was used or is used, in lymphomas also. So rituximab, a very important drug. Interleukin-6 receptor antibody tocilizumab. You must have heard this name in COVID now. In COVID, they are using tocilizumab very frequently. It's again an experimental drug there, but it does seem to work in some select patients who have interleukin-6 levels elevated. And JAK inhibitors, JAK kinase inhibitors, Janus kinase inhibitors, two of them, baricitinib and tofacitinib. So what I'm going to do at this moment is I'm going to hold on at this moment and I'm going to ask you to click a picture of this slide or write down this. I'm going to give you 2 minutes. I'm going to hold at this point, and then I'm going to describe how do I select which of these drugs. There are some markers which help us to select which of these drugs do I want to use, and what are the extra precautions I need to take when I'm going to select a patient on biologic. So I'm just going to hold on quiet for the next minute or so, right? So please write down these names. Some of you must be already knowing these names. For some of you, these might be new names. Please write down all the names that are on the slide, right? Apart from anakinra and certolizumab, everything else is available in India. I'll tell you which of them do I use frequently and how do I make a choice. Clinically, what are the parameters that help us to make some choice. In the meanwhile, Aishwarya, can I request you something that can you please go through the chat box? I can see there are some questions which are coming up. If you can screen the questions for me, I will take those questions which you highlight and ask me to take. Right?
Yes, sir. We'll be doing that, sir. So once you finish with the
talk, this is my last slide. After this, I'll just finish off describing how they are being used, and then it's open for questions.
Yeah, sure, sir. I'll filter out the questions from YouTube as well as Zoom.
Yeah, thank you.
Thank you, sir.
Okay, then. So what I'm going to do is I'll go one step further. I'll come back and keep this slide up if anybody needs to kind of copy this down. So let me discuss with you what are the precautions or what do I think of when I'm thinking of biologic agents. Now, there are two big concerns. This is real world that I'm talking about. What happens when I'm taking these decisions in real world? There are two big concerns when I'm thinking of biologics. First and the foremost concern for me is infections. One of the biggest problem with biologics is they can increase the risk of infections. And if the patient already has some infection underlying, it can get flared up. And which infections are we talking about? There are two big infections that I'm always worried about. First, of course, in our country is tuberculosis. So before I give this drug, before I give any of these drugs, I need to be very sure that my patient right now does not have tuberculosis. Remember with Methodics also I said the same thing. I said we'll do an X-ray, but I said it's an optional thing. If I can do it, then I'll do it. If I can't, then it's okay. I'll just monitor and ask the questions. Not so with these drugs. These drugs are quite expensive, and the risk of infections is higher than with methotrexate. So I will have to be extra careful. And before I give this drug, I have to screen the patient for what is known as latent tuberculosis. Latent tuberculosis means hidden tuberculosis. If the patient has symptoms of TB, of course I can't give the drug. But even if the patient does not have symptoms of TB like fever, anorexia, weight loss, cough, if the patient even does not have that and says I have no contact with TB, I still need to screen the patient. And very often the test that we do for screening patients for latent tuberculosis is, you might have heard these names, these are known as Mantoux test, and also what is known as the quantiferon test or interferon gamma released assay. Interferon gamma release assay, also known as quantiferon test. So these Mantoux test and quantiferon test, these are tests that are done to rule out whether the patient has any evidence of hidden or latent tuberculosis. Apart from tuberculosis, the other infection that I'm bothered about is hepatitis, especially hepatitis B. So I'm going to look for hepatitis B surface antigen positivity or anti-HCV. Of course, I'm also going to look for the third H, which is HIV. I don't want the patient having any of these infections when I'm going to give the drug, right? So the infections are one of the primary concerns that I have. I would also screen the patient with an X-ray. I would very often do a CT scan if I'm having any suspicion of this. So there are a variety of other battery of tests that I do, but all the tests are geared towards ruling out infections. Not only do I don't want the patient to have infection when I start, I don't want the patient to develop infection later on. So when I start these drugs, I should advise the patient about personal hygiene. COVID has done one good thing, I would say. The respiratory infections otherwise have gone down because people are wearing masks and social distancing has improved. So at least, in that whole of the bad things that we are seeing, there is one silver lining that some infections have come down thanks to the social hygiene that we are seeing. But we need to continue that. We need to tell that to all these patients that they need to be taking care of themselves. And the slightest evidence of infection, they need to report to their doctors and get antibiotic covers and otherwise. Vaccinations are also very frequently done. Very often before I give these drugs, I would vaccinate the patient for influenza vaccine. I would vaccinate the patient for pneumococcal vaccine. I would give these vaccines, influenza and pneumococcal vaccine, before I start the patient on biologic drugs. One of the things I need to be careful about before I start this is infections. If the patient already has an infection, I need to treat that infection before I start the biologic. I cannot start the biologic straight up. But the other thing I need to be careful about, and I need to tell my patient about, is cost. And unfortunately, that is one of the primary driver of this in our country. Remember, these are state-of-art therapies. They were discovered using a lot of course, a lot of research has gone into getting these drugs into the market. So the cost is very high. And despite the fact that India has been at the forefront of making what are called biosimilars. Now, some of you must be aware of this term, but some of you might have this term as new. So there are some drugs known as biosimilars. Biosimilars, to keep it simple, have the similar final molecule, the final antigen that they are going to target, but the molecule, the protein per se, is going to be different. For example, when we think about all these biologic drugs, their original molecule is going to be quite complex, a huge protein. It's not going to be a small protein. It's going to be a huge protein that this molecule is. Replicating it as such is going to be difficult. Biosimilars have the overall molecule three-dimensionally slightly different from the original biologic, but their final end product, the antigen that they are targeting or the protein that they are eventually targeting, most of them are antibodies, is going to be constant. So their effect is same, but the structure is similar, not exactly the same as the original biologic. Biosimilars have changed the game for India. Because in India, we are one of the leading producers of biosimilars in the world. We don't make a lot of biologics. I think we don't make any of the biologics, but we make a lot of biosimilars, which are available at lower cost. And that has made these drugs a little more accessible to our population than they were earlier. Right? So nowadays, what we use very often is not biologics, but biosimilars having similar efficacy, similar actions, similar names, but not the original. So for example, you can have etanercept as a biologic, You can also have etanercept as a biosimilar. You can have infliximab as a biologic. You can also have infliximab as a biosimilar. But there are some drugs where it's only the original biologic that is available, not the biosimilar. But cost is something that a patient have to really worry about. And that's why cost matters is, well, some patients might not want to initiate itself. They might say, okay, the cost that you're telling me is really so high that I cannot start the therapy. But a lot of patients do start the therapy because the pain is so severe, they have not responded to the earlier drugs, but they might want to take a shorter course. Now, this is something where science comes in a little conflict, because we don't have real evidences to say how short courses are to be used. For example, if you look at the trials which brought these drugs into the market, all these trials have run for a course of 2 years to 5 years. When my patient takes the drug, to give you an idea, these drugs might cost the patient on a lower side somewhere between 15 to 20,000 rupees per month. In today's date, we are right now in September 2020. So 15 to 20,000 rupees per month is going to be quite expensive for a lot of our patients. And then telling them you take this per month this way for 2 years to 5 years, difficult. Taking methotrexate, which might cost like 200 rupees a month maybe, is going to be quite easy. Compared to that 20,000 is really, really difficult. So in India, we have to tailor, because of this cost, drugs are given for a shorter duration. 3 months, 6 months, maybe 9 months to 1 year is when we need to stop these drugs. That makes our practice a little different from what you might read it in the textbook or what you might see in the Western countries. But in India, we have to give these drugs for a shorter duration and shift back again to our conventional DMARDs. Right? Now, finally, what really is happening in RA then? In RA, I am starting my patient on methotrexate. Very often after methotrexate, I am giving these options, but most of my patients are selecting this. A good number of patients will get controlled with this combination DMARDs. Some patients who will not get controlled with combination DMARDs eventually will have no other option but to shift towards biologics. And with biologics, a good number of patients do get under control, but unfortunately they can't manage the cost. So I do come back to this and say, okay, let's continue to control you with this. After the initial maximum inflammation has come down, I continue to control you with this. I told you right in the beginning that methotrexate, if the patient responds, I might stop the therapy in 3 to 5 years. Now that's a dream. Most patients would not respond to only methotrexate. They will respond to so many other drugs that I had to give. And when there are so many other drugs that I have given, the response is not going to be complete. I might want to extend the therapy longer. That gives us the bad name that people say, ek baar dawai shuru hoti to kabhi band hi nahi hoti. I don't think that's completely correct. If treated well, there are patients where you will be able to taper down the therapy to very little eventually. When can we stop? Very difficult question to answer. Very individualized, depends on patient to patient. The answer will require good monitoring, and it will require good kind of trust between the treating physician and the patient, because they need to understand what are the trade-offs when we are going to stop therapy. 2 last questions before I stop. What about NSAIDs, painkillers? NSAIDs are not wrong. We use NSAIDs, but they are not the drug of choice. They are not what are going to stop the disease from going ahead. They're only going to give symptomatic relief. So yes, NSAIDs should be used SOS as required. Second question, what about steroids? You never mentioned steroids. Well, there is a reason why I did not mention steroids. Well, what? Steroids are not the drugs for rheumatoid arthritis. I repeat, steroids are not the drugs for rheumatoid arthritis. They can be used, but that doesn't mean they are the drug of choice for rheumatoid arthritis. Some of you said it's a drug of choice. It is not. So they can be used, but they are not the drug of choice for rheumatoid arthritis. They are the drugs that I would prefer in conditions like SLE. Since SLE is one of the, again, rheumatic condition. They are the drugs that I would use there. I would use steroids here for only a very short period. So I'm going to quickly write down how do I use steroids in rheumatoid arthritis, and that's the last thing for you from my side, and then I'll take your questions. So how do I use steroids in these patients? Well, when I want to use steroids in a patient of RA, first things first, the rule is simple, use the lowest dose. And when we say lowest dose, the dose should technically be kept less than or equal to 7.5 milligram per day of prednisolone. Keep it for the lowest duration. When I say low duration, that means I would want to stop it within a period maximum of 3 months. So a short period of steroids can be used. Remember, I told you methotrexate is going to take some time. So very often I would use steroid to initiate therapy. In the very initial phase where methotrexate has not yet acted, I might be justified in giving a short course of steroid after, of course, ruling out any contraindications. Second thing is, remember, sometimes you might have a patient where, let's say there were 10 joints which were painful. You started the patient on therapy. Half a year down, all joints have improved. Just one joint continues to hurt. The knee joint is swollen and only the knee joint hurts. Now, very often there is a case that instead of increasing the DMARDs, I might take a steroid injection and give it directly in the joint. If there's only one joint which is troubling, that is intra-articular steroid. So please remember, if there is a single joint disease that remains, other joints have improved, then you might use intra-articular steroids like triamcinolone, Kinocort. There are different formulations that you can use. Intra-articular steroids can be given in a single joint, usually a large joint like knee. But this is not to be done when there are multiple joints involved. This is to be done when everything else has settled, just few joints are remaining, right? So with that, as I promised, I'm coming back to this slide and I'm going to say thank you. And I would like to take your questions at this moment. I'll keep the slide up and over to you, organizers, whatever questions you have for me. Thank you.
Yes, thank you, sir. So this was a very interesting and informative session. You really explained the therapy right from DMARDs to the biologics to biosimilars which are used, and the monitoring and the investigational parameters also. So there are a few questions. The first question is, how long will it take for leflunomide to be completely removed by chelating agents?
So the chelating therapy is usually given as a course of 11 days. So it's an 11-day course.
Yes, sir. The next question is, if you start the patient, if the patient develops methotrexate-induced anemia, then will the methotrexate be continued? If yes, at what value or range of hemoglobin will you consider stopping methotrexate?
That's a very good question. And there is no one straightforward answer to that question. I would like you to think over this a little. I said right in the beginning that rheumatoid arthritis itself can cause anemia. Now, if rheumatoid arthritis has caused anemia, that is because rheumatoid arthritis is an inflammatory condition and it's a chronic inflammatory condition. Chronic inflammatory conditions are known to suppress the bone marrow and cause what is known as anemia of chronic disease. And rheumatoid arthritis is in the world the most common cause of anemia of chronic disease. So when I start a patient on treatment for rheumatoid arthritis and he already has anemia, that anemia before I start methotrexate is because of RA. When I use methotrexate, which is very likely I will control RA, and as I control RA, I'm controlling anemia. The hemoglobin actually will improve. Of course, remember, whenever I give methotrexate, I have not said this during my presentation, but it's a known fact that whenever I give methotrexate, always, I give folic acid along with it. So I have to ensure that along with methotrexate, I'm giving folic acid, and that should take care of the anemia part. Now, if suppose there is a immunosuppression that is occurring because of methotrexate and that is causing anemia, first of all, that's not my first diagnosis. Very often that does not occur. Most of the patients, the anemia improves after I start methotrexate and control RA. But if at all the hemoglobin drops and I find no other cause, I have to evaluate the patient. And I say that, okay, this is only because of methotrexate. Then usually with the hemoglobin drop of more than 1 to 2 gram per deciliter, or the actual count of hemoglobin coming down below 8 to 8.5, is when I would consider discontinuation of methotrexate. But again, I would reiterate over here, most of the times it is not methotrexate which is causing it. It is the drug, it is the RA or something else which is causing anemia, and I should find that cause and not blame methotrexate for it. That is what I need to remember. Sometimes you might see a very peculiar problem. Methotrexate is to be taken once in a week. We told the patient to take it once in a week. We wrote down once in a week. Patient did not realize this was the tablet to be taken once in a week and ended up taking it every day. You ended up having methotrexate toxicity. Those patients can come to you with anemia, pancytopenia, in fact. That time you might want to, of course, discontinue methotrexate and start the patient on folinic acid. Usually I would give folic acid, but if I encounter toxicity, and I'm sure this is toxicity, and that has caused bone marrow suppression, I give folinic acid. Those patients will come to you not only with anemia, they will also come to you with skin ulcers, sometimes oral ulcers, all the hair loss and multiple features of methotrexate toxicity. Right, so that's my answer for it. If there is a follow-up question, I would like to take on that.
No, sir. Thank you, sir. Another question is methotrexate can induce pulmonary fibrosis. So, do we give any drug prophylactically for it?
So that's again overstated fact. Just before we started this one, I was in a kind of a meeting with some rheumatologist, and we were having a discussion on methotrexate and its adverse effects. So we were just seeing some data also on this. It's a myth. It's a myth. So I'm not saying that methotrexate does not cause fibrosis. I'm saying the amount of fibrosis that methotrexate can do, or rather number of patients in which methotrexate can cause lung fibrosis versus the number we suspect them is really wrong. Remember, rheumatoid arthritis itself can cause ILD, that is lung fibrosis, interstitial lung disease. Methotrexate can sometimes cause pneumonitis, acute inflammation, which is idiosyncratic. And if that occurs, of course, you have to stop methotrexate. But that is in very few number of patients, which can occur in few weeks to few months after methotrexate has been started. Sometimes can be a long-term complication. And if that happens, very often the patient will have a sudden worsening. Lung fibrosis, which is because of RA or which is usually the chronic lung fibrosis, that is a very slow progressive disease. Patient will have cough and shortness of breath, which will gradually progress over 3 months, 6 months, something like that. If methotrexate is the culprit, patient will deteriorate within 2 months. So the presentation is very different. The CT scan will look very different. There is no way you can prevent it because it is not dose related. It is idiosyncratic reaction of methotrexate. That means it can even occur at the lowest dose. It can occur at the maximum dose. It might occur in the patient who, the first time you use it. It might occur in the patient few months after the patient seems to have tolerated it. And because that number is so small, we do not have enough evidence to say that something can prevent it. So we can't prevent methotrexate-induced lung fibrosis. The good news is it is not common. What is common is the patient has ILD because of RA, but unfortunately methotrexate is the bichara one who gets the blame for it. It is not because of methotrexate in most cases.
Yes. Thank you, sir. One question from YouTube. If the patient already has hepatic or renal diseases, then what drug will we give?
A tough question to answer, because if there are both, you have very little choice left. Let's hope the patient has only one of them and start with that. So if the patient has a proven hepatic disease, and with hepatic disease, the patient has a SGOT-PT which is elevated. That means there is hepatitis, not just a hepatic disease, but hepatitis, inflammation happening in the liver. Methotrexate and leflunomide are not used. We don't use those drugs, right? If the patient has hepatic disease, then preferably I will go with hydroxyquine, which is the safest for liver disease because it gets only renal excretion, and sulfasalazine. There are some reports of sulfasalazine also causing liver damage, but most often sulfasalazine will be considered as safe for liver. So you can use hydroxyquine and sulfasalazine for liver dysfunction. If there is a renal dysfunction, then if the creatinine clearance is more than 30, you can give methotrexate. Most of the nephrologists would agree that methotrexate is okay. We keep the doses low. We don't give the full dose. We might go up to 10 milligram to 15 milligram per week if the creatinine clearance is more than 30 but less than normal. Normal is 90. If the patient has creatinine clearance less than 30, I would not give methotrexate. I would preferably not even give leflunomide. I would give something like sulfasalazine and a lower dose of hydroxyquine while monitoring for retinal toxicity. Biologics, now there is data emerging on which one is safe in which, and we are now having permutation combination, but by and far the rule is if there is hepatitis B as the cause, we don't use biologics at all. The hepatitis B is the one that is the most difficult to manage because it can go into a fulminant hepatitis B once we give a biologic, especially anti-TNF agents. So there we stick with the conventional drugs rather than going on this side. That brings us to steroids. Steroids can be used if the patient has liver disease. Steroids can be used if the patient has renal disease also. So a lot of times in such patients, you might have to rely on low doses of steroids along with the DMARD that the patient tolerates. So that's my answer.
Yes, sir. Question from Zoom. If a patient develops TB after being on anti-RA medications, then should we stop the treatment to start ATT?
Answer is yes. You will have to stop the drugs. But again, there sulfasalazine can be continued, hydroxyquine can be continued, methotrexate, steroids, and leflunomide are stopped. Sulfasalazine we very often restart after we start anti-TB medicines. We wait for 2 weeks to 4 weeks depending on the patient's scenario and how much and where is the TB and what is the magnitude of the disease. But after 2 to 4 weeks, you can restart sulfasalazine. Hydroxyquine, we don't even stop. We continue hydroxyquine. But methotrexate, leflunomide has to stop. Biologics definitely have to stop once someone has TB, and they have to stop throughout the duration of the anti-TB medicines. After anti-TB medicines are discontinued, if you still need to give biologics, they are given but not preferred. As far as possible, I'll avoid them. But if there's no other choice, if the patient is in severe pain, I will give it after tuberculosis has been treated.
Yes, sir. One more question. There is an increased risk of metabolic syndrome in RA, which can increase the risk of cardiovascular disease, especially in women. So how can we reduce the risk of metabolic syndrome, and how do we manage the cardiovascular complications in RA?
So first of all, I would like to really congratulate the person who has asked this question. Most people don't know about this. It's really wonderful that I was not really expecting this question. Rest of the questions, I will be very honest, are okay. I expect them, but this one is really fantastic. So to the person who has asked these questions, my congratulations that you know that there is a risk, cardiovascular risk, and that is true for all chronic diseases. So yes, how do we tackle that cardiovascular risk or metabolic syndrome risk? Well, couple of things. Remember, all chronic inflammatory states, whether it is this, whether it is COPD, whether it is CKD, they increase the cardiovascular morbidity, they increase the risk of developing metabolic syndrome. So you need to advise patients on the non-pharmacologic aspects like dietary modifications. Now, a lot of people, believe that India में बहुत बड़ा myth है कि खट्टा खाने से arthritis होता है. इस myth का हम कुछ नहीं कर सकते, है तो है, ठीक है. Many people believe that you eat sour food और उससे ये होता है. There is no evidence of that. There is no evidence to say कि खाने का इससे कोई संबंध है. But there is reasonable evidence to say that salt intake does increase the risk of having, higher level of inflammation. There are some reports of that. So yes, you can of course ask the patient to have low salt diet that improves the blood pressure also. Ask the patient to be as active as possible. The more active the patient is, better is the weight control, better is the metabolism that happens. So as active as possible. Full-fledged exercises might not be possible to the patient when the inflammation is high, but once the inflammation settles, when the joints are better, you can ask them to start doing exercises. Having a low-fat diet, maintaining the body weight, maintaining a low-calorie diet or a calorie-restricted diet to keep their weight under control is very important. That's one part. Second part, as the person who has asked the question has very beautifully highlighted, these are women. And unfortunately in women, the suspicion of metabolic disease, the syndrome of suspicion of cardiac diseases somehow is a little lesser. We should not do that. We should encourage these patients to have regular blood pressure checkups. I told you leflunomide, steroids, these can increase the blood pressure. So you should keep them under good blood pressure checkup. In my practice, very often, every 6 months or a year, I would get the lipid profile done, the sugars done, the thyroid profile done. So we need to actively monitor them for these things. If they develop anything of this, they need to be very aggressively controlled on that. Statins for their lipid profile control, metformin for their diabetes, and if they have thyroid disease, then of course control that. So all these steps, it's a multi-pronged approach that you need to take to control their cardiovascular and metabolic risk factors, right? So thank you for that question. It really is a big concern, and increasingly as we realize that our drugs can control arthritis, we need to now look at the other factors which can damage our patients, and this is the next big factor, metabolic syndrome, after arthritis gets controlled.
Thank you, sir. What will be the management of patients in conditions like AIDS and RA?
So very often now AIDS बहुत कम हो गया है. I would say we have people living with HIV. There is a difference. AIDS is when the patient has already developed opportunistic infection. So if the patient has already developed opportunistic infection, then you might be very restricted in your choice. Maybe you'll just stick to hydroxyquine. That's about it. And sometimes SOS, thoda dose mein steroid de diya under monitoring, something like that. But that's not what we see nowadays a lot. What we see is people living with HIV and having rheumatic disease. I should highlight over here that a lot of these patients would rather have psoriatic arthritis. That's a common association with HIV. So if the patient is on antiretroviral drugs, while monitoring the patient's viral load and CD4 count, lower doses of these same drugs can be used. Again, wherever possible, the principle is same. I would prefer hydroxyquine and sulfasalazine, which are my minor drugs, rather than the methotrexate and leflunomide, which are my major drugs. But under monitoring, I can use the same drugs for HIV patients as I'm using for my usual patients. What changes is not the drugs, it's the monitoring. I need to look at their CD4 count, I need to look at their viral loads, and they should be on antiretroviral drugs. I can't do this. I started them on anti-rheumatic drugs and did not give them anti-HIV drugs. It has to be anti-HIV drugs first, control the viral load, get the CD4 count normalized, and then start. As most of you must be aware now, India's guidelines also endorse that all people living with HIV from the time of diagnosis are started on antiretroviral drugs. So we don't really now see that situation कि AIDS होने तक हम रुके थे, फिर दवाई शुरू हुई तो क्या किया. So that era is gone. We can treat them almost the same, just monitor them better. Biologics are something we would avoid, but rest of the drugs are similar.
Yes, sir. What if the triple therapy and the biological demands don't work? Then what should we go for?
See, it is not very common that they don't work. But if by chance you find that it doesn't work, then your best option is use some other biologic. So again, triple therapy doesn't work, I'll go to biologic. But when I go to biologic, within biologic, you saw there are so many types. I can select a biologic from some other category. So now again, there are guidelines within that. For example, anti-TNF were the first biologics to come. So we know that if someone fails on anti-TNF, now we can go to something else like maybe rituximab or something like baricitinib or the JAK inhibitors, which are the oral drugs, newer ones. We can go to one of them. So we can select from the other group. But again, it's not very common for people to fail on biologics. There are, of course, some patients. All of us have seen those few patients, but that's not the norm. Most of the patients on biologics do well.
Yes, sir. So we have a few more questions. Do you have time to take it up?
It's up to you, whatever you say.
What do we prescribe vitamin supplements in case of RA?
As I said, folic acid is a must when we are giving giving methotrexate. Vitamin D and calcium is something I would very often give initially. When I start my therapy, vitamin D is something I would start with. When I start my therapy, calcium is something I will start with. Very often, vitamin D after the first 8 weeks or 4 weeks of weekly therapy, I will shift over to 60,000 international units as monthly therapy. And that I would continue for a very long time unless the patient tells me that the sunlight exposure is adequate. Calcium, initially I would start with something like 1 gram per day. And then I would come down to something like 500 milligram per day. And I would continue calcium throughout the therapy unless there is a contraindication. Osteoporosis, I did not go into that part, but osteoporosis can be an association with rheumatoid, especially if we are looking at someone who's a little elderly or someone who has got a lot of steroids before they came to us. So there you might have to deal separately with osteoporosis and give them drugs like bisphosphonates to control that osteoporosis also. So yes, we give calcium, we give vitamin D, we give folic acid. India is one of the largest vegetarian population in the world. So we expect a lot of our patients to have B12 deficiency also. Even if they are non-vegetarian food eaters, they still can end up having B12 deficiency because the overall intake of non-vegetarian food is not very high in this country. So B12 deficiency and their symptoms need to be watched out for. Remember, they can also come with tingling sensation, and sometimes patients get confused that I'm having discomfort. So we need to be very clear in our history. Are we dealing with RA symptoms, or sometimes it could be B12 deficiency symptoms? If that happens, you might have to give them B12 also. But that's only if there is a suspicion. Otherwise, folic acid for everyone, vitamin D initially for everyone, later on for most of them, calcium initially for everyone, and later on also continue for all of them.
Yes, sir. So we talked about leflunomide, which can be removed by chelating agents. So can you name some of the chelating agents which are used?
There's only one, cholestyramine, that is what is used.
Okay, sir. So one more question. What will be the management of RA during pregnancy?
Okay, so RA during pregnancy, before pregnancy and during pregnancy and after pregnancy, 3 ways. Before pregnancy, I would want that the patient has a controlled disease for at least 6 months or more. That means she has no swollen joint, she has no tender joint. I'm talking about ideal. This might not be always possible, but what I want is this, that her disease is controlled. Before pregnancy, 3 months before pregnancy, I would want to discontinue methotrexate. That is why I want the disease to be well controlled, because when I stop methotrexate, she might flare up again. Then I would continue her on hydroxyquine and I would give her steroids SOS. If the disease activity is high, I might even consider giving sulfasalazine till the point that she gets pregnant. But once pregnancy is confirmed, if the disease is well controlled, I would want to stop everything or maybe just continue hydroxyquine. During the pregnancy, first trimester, I would usually give hydroxyquine and avoid giving any other drug. If I need to, I can give sulfasalazine, but as far as possible, I'll avoid giving anything else, continue only on hydroxyquine. From the second trimester onwards, I can give hydroxyquine and sulfasalazine. Till the last few weeks of pregnancy, delivery, I can also use steroids SOS for these patients. Post-delivery, again, till the time the mother is lactating, I cannot use methotrexate, I cannot use leflunomide, I can use the other drugs. What about biologics? Most of the biologic, especially anti-TNF agents, are now considered safe, reasonably safe in pregnancy, to be used only if very necessary. Again, nothing is 100% safe, so we have to be extra careful in times of pregnancy. But as of now, what it looks like is anti-TNF agents. If you ask me that, can I use a biologic, the disease is very high, I'll say maybe I'll consider using anti-TNF agent.
Thank you so much, sir. With this, we have come to an end of the question answer session. Thank you so much, sir, for this marvelous and enlightening session. All of us gained immense knowledge through the session. I'm sure all the doctors, as well as the Pharm D doctors, as well as the students, have gained immense knowledge. On behalf of the whole Pharm D community and all the participants, I would like to thank our speaker for today, Dr. SUSHANT SHINDE, sir. I'm thankful to you, sir. Even during such difficult times of COVID-19, you delivered this lecture for the benefit of all the students. Lastly, I would like to thank all my participants who took up time and have attended the session. Hope these webinar series help everyone during this pandemic time where we are missing upon the hospital postings. Thank you so much, sir.
Thank you so much, and thank you for all the participants. Goodbye and Jai Hind.
Thank you, sir. Participants, I'll be posting the registration link for our next session. So please do register as soon as possible.